The views expressed in this podcast are my own and those of my guests. They do not represent or reflect those of UCSF Health or my professional and clinical roles there. The content is intended for informational purposes only and is not medical advice. Please consult a qualified healthcare professional for specific medical guidance. Hi, and welcome back to In the Loop with Nadia Vlasiuk. Today's episode feels like it should be simple. It is. And it isn't. And it matters more than people think. I'll be discussing the electrocardiogram, or ECG, or EKG. They all mean the same thing. What it is, what the squiggly lines mean, how to read them in a way that's consistent, what each lead is actually showing you, and why electrode placement is not optional if you care about doing this well. There's even a pop culture moment as a reference point. There's a scene in the Pitt where Dr. Robbie zeroes in on an ECG and immediately recognizes something's off. He's not reacting out of emotion. He's responding to a real problem. The EMTs had placed the leads too inferior, which means too low, on this patient, so the ECG didn't pick up a lateral STEMI, which is a major heart attack, an ST elevation myocardial infarction. This is a plumbing problem. And then the patient went into ventricular tachycardia, or VT, which is a cardiac arrest and an electrical problem. So she had both a heart attack and a cardiac arrest. These are not the same things. The heart attack, the plumbing problem, can cause the cardiac arrest, the electrical problem. Stay tuned for an episode on cardiac arrest and sudden cardiac death. So what you're seeing in that moment with Dr. Robbie, that's not attitude and it's not just his personality. It's clinical recognition that the data is wrong and it changed the outcome for that woman. And you should know women are statistically underdiagnosed, undertreated, and understudied. More on that later. Earlier this month, I volunteered with UCSF PlaySafe Sports Medicine program for their PlaySafe cardiac physicals. I personally did 63 ECGs on student athletes. There were several rooms running ECGs, and I did mine one by one, over and over again, with the same lead placement every time. I wasn't guessing. I was finding and using the same landmarks every time. So let's get into it. The history of ECGs. The first successful recording of electrical rhythm in the human heart was likely achieved by Alexander Muirhead in 1869. And the first human ECG was recorded in 1887 by Augustus Waller. It wasn't really usable. It was more like, okay, well, we see electricity exists. Then Willem Einthoven, a Dutch physician and physiologist, comes along in 1903 and he changes everything. He builds the string galvanometer and defines leads 1, 2, and 3. He gives us the framework we still use today, Einthoven's triangle. He won the Nobel Prize in 1924 for his discovery of the mechanism of the ECG. So when you're placing ECG leads, you're not just placing stickers on someone. You're recreating a very intentional system that was built to measure electrical direction across the body. So what is an ECG? It's simply voltage over time. That's it. It shows direction, magnitude, timing, electricity. Anchored to that, our EKGs may feel confusing forever. Before we talk about leads and before we talk about the complexes and the squiggly lines and all of that, we need to talk about how the electricity normally moves through the heart. The electrical impulse should be initiated from the heart's natural pacemaker, which is the sinoatrial node, or the SA node, or the sinus node. We're not talking about sinuses in your head. We're talking about the sinus node in your heart. This is found in the high right atrium, which is the top right chamber of your heart. There's a little structure there shaped like a banana, fun fact, that is the SA node. This is your heart's natural pacemaker and where the electrical impulse starts. Then electricity flows through interatrial tracts across the atria, through the Bachmann's bundle, and down to the AV node. Once it reaches the AV node, it pauses and then runs down the bundle of His through the right and the left bundles into the Purkinje fibers. And that is how electricity should be moving through the heart. So let's talk about the basic complexes: the P wave, the QRS, and the T wave. The P wave is atrial depolarization. Depolarization tells the muscle to contract. So that's the electrical activity moving through the atria, forcing them to contract and push blood into the ventricles. The QRS complex is ventricular depolarization. And this is the big complex on an EKG because ventricles are more muscular and they're bigger than the atria. So the QRS is showing us the ventricles firing and squeezing out all the blood to the lungs and to the body. The T wave shows ventricular repolarization, which is recovery of the ventricles. So every time you look at an ECG, you're watching that sequence over and over again. Atria, ventricles, recovery. We also look at the different intervals: the PR interval, the QRS interval, and the QT interval. Those are telling us how long things take. So if you think about the electricity of the heart, it's basically us watching the electricity move in time. Before we get fancy with interpretation, we should be able to look at it and say, do I see P waves? Do I see the atria contracting? And what is the relationship to each P wave with the QRS complexes? Is there a P wave for every QRS? Are there more P waves or more QRSs? That's going to tell us a lot of things. Is the QRS narrow or is it wide? And are the timing of all of these intervals, is that normal? This is the foundation. So let's talk about the leads now in a way that actually clicks. This is where people just memorize things and then they get lost because you aren't visualizing what this electricity is showing us. So if you can think, when I described how the normal electrical activity moves through the heart, you can see it going across the heart and how it does that, right? So you want to think of every lead as a camera angle. You're building a 3D electrical map of the heart. So let's start with Einthoven's triangle and the 3-limb leads. These are bipolar, which means that they measure the electrical potential difference between two specific electrodes, a positive and a negative pole. Thus, they're comparing 2 points. Lead 1 is right arm to left arm, so think that it's looking across the top of the heart. Lead 2 is right arm to left leg. This lines up with the natural direction of depolarization, like I described before, which is why it usually looks nice and upright. Lead 3 is left arm to left leg. Check out page 44 of Dubin's Rapid Interpretation of EKG's book for a great visual. Now let's talk about the augmented leads. AV just means augmented voltage. They're unipolar, 1 point looking at the heart. So just translate them. AVR, right arm, looks from the right shoulder. It's usually negative. AVL, left arm, high lateral. AVF, foot, looking from the bottom, inferior. So where do we place the electrodes on the body to create these leads on the ECG? Well, it's pretty simple. Right arm, right leg, left leg. That's the correct placement. In practice, sometimes in the hospital setting, people will place them on the torso for convenience or speed, but you have to understand that that's a modification. The true standard placement is on the limbs. And even if you're placing them on the torso, you still have to preserve the geometry. Right is right, left is left, upper is upper, lower is lower. Because if you mix that up, you flip the axis or distort the entire ECG. So this is not random placement. You're recreating a coordinate system. And if the system is wrong, the data is wrong. Now the chest leads. These are the precordial leads in your horizontal plane. And when you place these leads on a patient, it's very important that you use landmarks. For V1, you're going to find the fourth intercostal space and place this lead at the right sternal border. V2, you find the fourth intercostal space and place this lead at the left sternal border. Now, we're going to skip V3, but we'll come back. There's a method to this madness. So for V4, we're going to find the fifth intercostal space and that midclavicular line, which is the imaginary line running halfway between the sternum and the body's edge from the clavicle. So that's where we place V4. Now, let's go back to V3. You're going to place V3 midway between V2 and V4. Then V5, you'll go to the fifth intercostal space and the anterior axillary line, so same level as V4. And then V6, you're going to put it same level as V4 at that fifth intercostal space, but at the mid-axillary line. This is where placement matters the most. Take a look at the show notes for a diagram of this. You're literally watching the wave move across the ventricles. V1 is over the right ventricle, so it's small. The S wave is deep, so it's mostly negative. V2, the R gets a little taller and the S gets a little smaller. The R wave transitions between V3 and V4, so you'll see equiphasic complexes or biphasic complexes, the same up and the same down. And then V5 and V6 are more over the left ventricle and the R waves are tall and dominant. This is the single most important concept in EKGs. If the wave moves towards the lead, it goes up or is considered positive. If it moves away from the lead, it goes down and it's negative. If it's sideways or the same up as down, it's equiphasic or biphasic, and that's it. That's why lead 2 looks the way it does, why AVR is negative, and that's why V1 starts negative and transitions. Everything builds from that. That's why it's so important that these leads are placed correctly so it can give clinicians the picture that they need to see so that they can know how to treat whatever's going on. So let's put it together. This is where it's useful. The inferior leads are 2, 3, and F. This is where your P wave should be positive if the electricity is moving from the heart's natural pacemaker. Lateral leads are 1, AVL, V5, and V6. The septal leads are V1 and V2, and the anterior leads are V3 and V4. You're memorizing, but you should also be visualizing, because if you visualize, these things will make sense. So let's talk a little bit about timing on the EKG. Every small box is 0.04 seconds. Every big box is 0.2 seconds. A PR interval should be 0.12 to 0.2 seconds, or 120 to 200 milliseconds. The QRS should be less than 120 milliseconds. In QT or QTC, which is the QT corrected, normal ranges for men less than 450 milliseconds and women less than 460 milliseconds. Children, it should be less than 450 milliseconds regardless of sex. So this is where people either become consistent or not. Not being consistent can be problematic. You have to read the ECG the same way every time. Rates, regularity, intervals, P waves, QRS, and their relationship, the axis, and transition. If you jump around, you'll miss things. Lead placement. If you place the leads wrong, you're rotating the camera, and you're not just a little off, but you're changing the data. And this is why that scene in the Pitt matters so much. Dr. Robbie is looking at an ECG, and it's not right. The issue isn't subtle. The EMTs had placed the precordial leads too inferior. Because of that, the ECG didn't capture the lateral STEMI, and the patient goes into VT. So he's not just being intense for no reason. He's reacting to the fact that bad lead placement didn't just make the ECG messy. It hid a life-threatening diagnosis. That's the point. If your leads are wrong, you miss real pathology. And in the wrong moment, that's not theoretical. That's dangerous. So the reaction was warranted. It's so important that we understand how much is riding on getting something that seems so simple right. And here's the thing, this doesn't start in emergencies. It starts with how you place the lead on every single patient because it matters. It's how we tell when things change and when we need to escalate care. Now let's talk about women, because this is where nuance matters. Women typically have more breast tissue than men. I know, I'm Captain Obvious. Guidelines acknowledge that this is tricky. Traditionally, clinicians were taught to place the electrodes under the breast, but the data shows that breast tissue doesn't really change amplitude. And sometimes putting leads on the breast actually helps you keep V4, V5, and V6 level, which is the whole point. Because if those leads drop too low, then your ECG changes. There's also patient preference. A lot of women either prefer on breast placement or don't care, as long as you explain what you're doing and you're respectful. This isn't just technical, it's how you show up. And honestly, it comes down to the question that Dr. Robbie so eloquently put to the entire ED. Death with modesty or life with brief nudity? Death or life? And when you actually look at the data and when you actually talk to patients, it turns out that women want to live. They want you to do it right. They just want you to do it respectfully. So the real answer is not always under, and it's not always on the breast. It's get the anatomy right. Keep the leads level. Be consistent. Explain what you're doing and document if you change it. Because as I noted before, we compare ECGs over time. If the placement changes, the ECG changes. And if we zoom out for a second, as I stated earlier, women are still understudied, underdiagnosed, and undertreated. And we will do an entire episode on just that. So bringing it back to earlier this month, I performed 63 ECGs with the same process every time. Find the landmarks, place the leads, don't guess. The bottom line is leads are viewpoints. Placement defines accuracy, and consistency protects your data. Honestly, that's the simplest way to say it. Precision is not complicated. It's doing the same thing correctly over and over again. Thank you for joining me for this brief episode on why lead placement with ECGs is important and a basic overview of the EKG. Thanks for tuning in to this episode of In the Loop with Nadja Vlasiuk. I hope you found today's discussion insightful and empowering. Feel like diving deeper into the topics presented today? Be sure to check out the show notes for references and more helpful information. You can also visit our Substack or Instagram, Facebook, and TikTok. Remember to stay curious and stay informed. Now you're in the loop.